Good afternoon and welcome to the Parkinson's Academy webinar. This afternoon we're going to be talking about managing the older person with Parkinson's in the time of COVID. We have three speakers this afternoon who are all experts in this area. I'll hand over to our first speaker first, who's Dr. Sarah Marrinan, who's a consultant physician in medicine for the elderly here in Edinburgh in NHS Lothian. She trained in geriatric and general medicine in the northeast of England and was a clinical research fellow at Newcastle University Institute for Aging and Health, where she did her thesis on Parkinson's. So I'll hand over to Dr. Sarah Marrinan first.
Thanks very much, Conor. Hi, hopefully everyone can hear me okay. I'll reassure you I'm not in a call centre, but I am in a hospital. But the headset is just the best way of you hearing without all the background noise. So I was asked to talk a bit about non-motor symptoms for older people in the context of COVID. And just kind of to say at the start, this is a fairly evidence-free presentation. This is really just based upon the things that I suppose I and our team here have been thinking about with regards to older patients with Parkinson's at the moment. And there'll be some more evidence coming later from Richard and Emily, but really just kind of thoughts on what we've seen over the last few months and the implications. So I'm going to touch on briefly really what's changed for our patients, and I think if we spend a bit of time considering what's changed, that helps us work out what we need to do. A little bit based upon the patient perspective, people I've been phoning over the last few weeks, things they've been telling us. I'm going to highlight the key non-motor symptoms that I think we need an awareness of at the moment. I can't say that I can give you definitive plans on how to fix some of these issues, but I think if we're aware of the challenges that we might see in this current unusual context, I think that's half the battle, is an awareness, and some kind of tips and suggestions of things we might be encouraging patients to do. So already this is out of date within a week, but we've all seen these slides telling people to stay at home, protect the NHS and save lives. And I think this message perhaps takes on a different context when you're speaking to people who have a health issue themselves. And so my experience is that our patients have been, really quite vigilant in staying at home and looking after their health and others. And that's really changed the context for a lot of our older people with Parkinson's who were always encouraging to get out, and now we're encouraging them to stay at home. And the implications of that are wide-ranging, and this is just a kind of an introductory way of thinking about it, but we are, in a sense, enforcing social isolation. We are reducing people's ability to exercise outside. I think early on, there was probably quite a lot of change in people's diets because people couldn't get to the shops, and even if they could, they weren't necessarily buying the things they usually would. I think lots of people have said that their sleep has been affected by all that's been going on, and obviously I think a potentially increased risk of anxiety and change in mood. Moving on to think about what's changed from an outpatient setting, I'm inclined to say everything, but really a lot has changed. At short notice, there have been cancelled appointments, uncertainty about whether people should attend in person, which I think is the propensity to increase health anxiety, potentially when some people already have a higher degree of health anxiety, and reduced interaction with healthcare professionals. And we know that people with Parkinson's are very engaged in their condition, but also work closely with their team. And so not being able to see people when they were expecting to is really important for us to bear in mind. In terms of what's changed in the hospital, well, I think it is fair to say that our focus has been on COVID. I have been essentially a COVID doctor for the last few months primarily. And thinking about those patients that are then in hospital at the moment, there's a huge amount of change. We're not quite wearing this level of PPE for most of our patients. They're not in intensive care a lot of the time, but we are hidden. We've got visors, masks, gowns, we all look the same, and that makes communication sometimes a bit challenging. I think that increases the risk of people becoming disorientated and delirious, and certainly that's what we're seeing on the ward fairly frequently. Also the absence of familiar faces. We rely heavily on our patients' families and being advocates for them when they're in hospital at times that they're delirious, and due to restrictions on visiting, families may not be there. And I think the last thing just to highlight is the redeployment of staff. A lot of nurses and healthcare professionals are being asked to work in unfamiliar environments. And I think we have to recognise that people may not be used to working and looking after older people, and specifically older people with Parkinson's. So I think our kind of role in education about the condition is almost a daily one at the moment. And from a patient perspective, I could probably write a long list of things that people have been saying when we've been speaking to them, but I think they're probably all the things that everyone else is feeling as well. They're not necessarily specific to Parkinson's, but they may have an impact on someone with Parkinson's to a greater degree. So people missing getting out, feeling they can't concentrate, more time to worry and think about their health and their symptoms, more time watching the news, and missing the routine of the exercise classes that we usually encourage people to go to so often. So thinking specifically about some of the non-motor symptoms that I think we probably need an alertness to in this context. And I think probably the biggest category would be to say neuropsychiatric or cognitive symptoms. And this is just to get us thinking about it. But I think obviously we need to worry about sleep disturbance. People, even though they're not perhaps doing as much physically, are saying that they're feeling fatigued. As I mentioned, anxiety and low mood, and I think it's very understandable for people to feel these symptoms more at the moment, given all the restraints and the wider context and concerns. I think people with and without Parkinson's have said that even though they've got all this time, they're sometimes feeling like they haven't got the motivation to do things, and that seems to be a kind of fairly universal feeling. I think some people have had more issues with disorientation and hallucinations, and I suppose the patients that I'm most concerned about at the moment are those with cognitive impairment who now have this new context and the potential for that to worsen some of their pre-existing neuropsychiatric symptoms. I think it's not a one-size-fits-all. I don't think we can give blanket guidance on how to manage these, but I think when we're seeing patients with Parkinson's in the hospital or speaking to them by phone, I think we need to spend a bit of time unpicking some of these symptoms and making sure that we're doing our best to support people in these strange times. I think the other thing, thinking specifically about medications and some non-motor symptoms, I think we need an alertness to issues with impulse control disorders. And we were chatting as a group just before this session began about how there's apparently been a significant increase in gambling. I think also we're all watching the news more, checking our phones more, and some of these kind of behaviours, and just making sure that those patients who either are at risk or have impulse control issues, that we're trying to make sure that we're supporting them and keeping an eye on those things. And I suppose linked, I haven't personally come across anyone who's developed new issues with dopamine dysregulation, but I think again we need an alertness to that possibility in that people are somewhat cut off from their usual support networks, both from family and the PD team, and the potential perhaps for people to use their medications in a way that they haven't before. And then I think some other things, constipation, weight loss, again, people's diet and their exercise have changed, and speech deterioration. I have a patient who has significant issues with his speech, but getting out every few days and speaking to people really helps him. That's his kind of real life speech therapy, and he's not getting that at the moment. So I think keeping an eye on those things as well. In terms of what we can do, again, this is very general advice, but I think we have to acknowledge that it's a strange time for everyone. And I think if we acknowledge and realise it, I think that's an important first step. A lot of this advice goes for everyone, whether you've got Parkinson's or not, but I think encouraging our patients to maintain a routine, because it will have, I would hope, positive effects on bowel function, sleep, mood, but trying to introduce a routine even if people are at home most of the time. Home exercise, whether it's Zoom, Pilates, or Joe Wicks. Perhaps for some of our patients it's maybe a slightly different type of exercise, but I think something physical each day. And I've very much been encouraging patients to look on, for example, the Parkinson's UK website, which has some really good links and advice for people on how to stay active even though they're staying indoors. I've spoken to a few patients who were doing PD Warrior before the pandemic and have picked it up again online at home. There is a cost associated, so it's not suitable for everyone, but I think that routine, almost that sense of challenge, something to aim for, is quite important. Again, this goes for all of us, but a balanced diet. But I think we have to recognise that our patients may not be able to get out to the shops, trying to encourage them to maintain that normal balance in their life, and likewise not too much alcohol, which may well upset the balance of things. Sleep, we all know, is vital in people with Parkinson's, and trying to get good sleep hygiene, going to bed at a regular time, getting up at the same time. And I think the temptation when you're not getting out of the house is to let those habits go. So I think it's simple, but encouraging people to try and maintain good sleep hygiene at the moment. And social support networks. For some of our patients, they're used to doing this all the time. For some, it's very new, but I think maintaining that contact, whether it's by phone or video with family and friends, to make sure that people aren't feeling as isolated as they might otherwise. And getting outside where possible, and that's easier for some people than others. The role of vitamin D in COVID is in the news currently, and I think the honest answer is we don't know, but probably getting some sunlight each day helps a little bit with day-night patterns and making sure people sleep well, and probably helps with your mood as well. And encouraging people as far as possible to relax. I think from a Parkinson specific point of view, we need to keep in contact with our patients, and they need to know that they can keep in contact with us. And that's different in different areas. For me, primarily, it's been phone consultations, video consultations we're working on at the moment. But really the key to this, certainly speaking locally, has been the PD nurses, who have been fantastic at speaking to our patients, keeping in contact with them, answering their queries, and I think importantly, giving a degree of reassurance that we're still there, and that there is a way of asking if they have queries or they have worries. So I'll finish there and hand back to Conor.
Thank you very much, Sarah. I meant to say at the beginning that if you have any questions or answers, there's a Q&A box on the screen. If you click on that, you can write in a question and we can put it to our speakers. I have one or two questions for Sarah. Over the last few months, like yourself, we have been doing telephone consultations, and there are two areas that have stood out. One are people with Parkinson's who have dysphonia find that extremely difficult. So we've had to speak to next of kin, and we've got patient feedback sheets, and some of the people with Parkinson's have written down, I found it difficult. I had my wife spoke on my behalf. So they felt slightly disenfranchised. And the other area that was really pointed out was the stress felt by the carers or spouses of people with Parkinson's who have dementia. And they say it's difficult coming to the clinic, but at least when we come to the clinic, I get a break, I get to speak to somebody else. Have you any comments on either of those or your experience?
I would agree. I think that the phone is good for some, but it's challenging for others. And I think you do miss that degree of eye contact, face-to-face contact, seeing how someone's looking. Are they looking dapper, smart, well turned out, or are they struggling? And you miss that. I think the speech thing is difficult, and I think we're all finding our way, whether email will have a bigger role going forward for some people who have particular difficulties. And I think you're entirely right about the other person. I think, we treat the patient, but we actually look after the person and their whole family and their whole life. And it's really important when they come to clinic. Usually people will bring a significant person, and, we talk as a group. And I think that is harder by phone. I've done a lot of, can you hand the phone to your wife now, and backwards and forwards. And I think that's better than nothing, but it does feel like a compromise. And I am missing being able to sit in a room and everyone see and speak at the same time. But I think it is important, where possible, to speak to the next of kin as well. I think that adds a really important dimension.
Because you're working as a COVID doctor at the moment, have you come across any people with Parkinson's admitted who are COVID positive?
Yeah, a few, and some with Lewy body dementia as well. And the numbers are small, so it's, I could count on one hand. I think some have had no actual significant change in their Parkinson's. A couple who've had quite low blood pressure in the recovery, they've got through the acute illness fairly well, but have a bit of fatigue after. And at that point, we've found some who've had quite low blood pressure. Orthostatic hypotension has been quite dominant. And I think that's probably just time, giving people time to recover. So we are seeing some. I haven't thus far, in the small number I've seen anyone where their Parkinson's themselves has radically deteriorated. I think because a lot of people are spending time in bed, feeling tired, and the focus really has been on kind of rest and getting through the acute viral episode. But later on, we may be able to hear others may have, different experiences.
Yeah, somebody has put in a statement just saying that they'd seen a couple of COVID-19 Parkinson's people, and one was hugely deconditioned and readmitted, and the other did very well. And I think we're similar. It's not just with people with Parkinson's, but a lot of older people are being deconditioned by what you said, not getting out, not exercising.
I think it's hard to predict as well. There are some people who come in who seem very frail with a lot of comorbidities and seem to get through relatively okay, and others where it affects them much more significantly. And I think that unpredictability is hard for all involved, the patient, the family, and the hospital staff as well.
And one last quick question. There are other questions that have come in, but I'm going to save them for the three of you at the end. Have there been any need to change medications? This is another question for people with Parkinson's admitted with COVID-19. Or do you notice any difference between somebody with COVID-19 being admitted and somebody with, let's say, pneumonia in the past?
Yeah. Not so far. I suppose the one specific context we've had is if someone has a hypoactive delirium and isn't able to swallow their medications. I've certainly been asked for advice in the last couple of weeks about switching to a retigotine patch in the short term due to a compromised swallow. I've been asked kind of remotely about a couple of other people whose mobility had deteriorated. I have to say it was very early in their admission, and my suggestion was we just give them a bit of time to get over the virus, a bit of time to rest, get over the delirium, and then adjust medications if we need to after a week or so. So nothing radical so far.
There's another question, a statement that has come in saying patients we have seen are massively impacted in their rehab by fatigue. And I think we're probably going to pick that up more with people with Parkinson's over the next few months, the fatigue that will be representing to hospital or clinics.
Absolutely. There's loads of it. And speaking personally, I had COVID and I felt very tired after. I think the other thing is the fatigue seems to be in some people quite a late symptom. So you get over the virus, the cough's gone, you start to feel better, and then you get tired. And we're definitely seeing that in terms of trying to rehabilitate people, get them ready for home. And again, some have very little, but some it's marked. And I think it seems to be suggested that in some people it goes on for many weeks. And again, it's the unpredictability makes that hard as well.
Okay. Sarah, thank you very much. Stay online because we'll be coming back at the end of the webinar. Our next speaker is Dr. Richard Genever, who's a consultant physician and movement disorders lead at Chesterfield Royal Hospital NHS Foundation Trust. He's also involved in the movement disorders branch of the British Geriatric Society. And can I recommend you all Richard's paper from the BMJ 10 years ago, Managing Parkinson's Disease During Surgery, which I keep referring to and keep referring my trainees to. So I'll hand over to Richard, who's going to talk again about Parkinson's in the time of COVID.
Thank you very much, Conor. So when I was asked to talk about this, I thought there were four things that I'd come across that I thought were interesting to look at. So the first of them is to clarify what is the current advice on what people with Parkinson's should be doing right now in terms of the lockdown and social distancing. I wondered about the question of whether people with Parkinson's are at more risk from coronavirus. Also, I was interested in whether the actual lockdown itself could be having an influence on people's Parkinson's symptoms. And then finally, there was just a specific thing that I came across about amantadine that I thought it'd be useful to look into and share in case any of us get asked a question about whether they should be started on amantadine at this time. So let's see if we can get this to move on to the next. There we go. Okay, so what is the current advice for people with Parkinson's? So I guess it's fair to say it's slightly confused. So up to the 11th of May, this was the government advice, and they created a group of people that they called vulnerable, but not highly vulnerable, and that included everybody over the age of 70, but also specifically they mentioned people with chronic neurological conditions, including Parkinson's. And the advice at that time was that anybody that fell into this category should be taking extra precautions. So looking at every situation on its merits and working out whether the risks of doing something were too great for them to consider. However, on the 11th of May, everything changed, and the government advice was different. And if you go to the government website, the stuff that was put out there was about 70-year-olds. But if you search for Parkinson's throughout the government advice, it's actually disappeared from all the guidance. So the question is whether the policy is now that people with Parkinson's don't need to worry unless they're over 70, or whether that's just been missed out in the sort of the heat of the moment. And so I'll come back at the end of my session to looking at what the advice probably is for those people. So moving on to the second question, are people with Parkinson's more at risk from COVID-19 infection? So the truth is that we don't know at the moment. This is a brand new condition and the evidence base is gathering. But there are possibly a couple of things that we can look at that would give us a signal and a suggestion about whether perhaps people are more at risk. So the first of these is to look at the age range of people with Parkinson's. And Parkinson's becomes increasingly more prevalent the older you get, until you get around 80 or 90. And if you look at the graph of age standardized mortality for people with Parkinson's, you can see that people who are most at risk are those in the oldest age group, so 85 to 89. So there's a very close correlation between the age group that are most likely to have Parkinson's and the age group that are most at risk from COVID. A second factor is comorbidities. So do people with Parkinson's have more comorbidities than other people, fewer comorbidities, and does that matter? So this paper, it's a large database study in Scotland, and that found quite a few interesting things, really. So the first of those, if you look at people who have no comorbidities, so people with Parkinson's were much less likely to have no comorbidities than matched controls. So already we're seeing that there's a pattern towards people with Parkinson's having other conditions more frequently. And then actually, when you look at people having multiple comorbidities, people with Parkinson's are more likely to have lots of other conditions. And this is most marked once you get up to 7 or more other conditions. So 12% of people with Parkinson's had 7 or more conditions, and just under 4% of matched controls did. And what sort of comorbidities are there? Well, everything really, but of the top few, 3 of them were things that do seem to have a recognised association with a poor outcome with COVID. So coronary heart disease, heart failure, and stroke. So again, another signal that suggests that people with Parkinson's may be more at risk of a COVID infection. I feel like I'm getting more phone calls than I normally would do from people with Parkinson's, family members, talking about worsening of symptoms. And I wonder whether the situation, particularly the sort of the lockdown situation, might be having an impact. And one of the symptoms I'm hearing about quite frequently from a motor point of view is freezing of gait. And I think there probably are reasons why freezing of gait might be more of an issue at this time. So here's a paper. It's from a few years ago, and it was a postal survey looking at 130 people with Parkinson's. Now you can see that there are people who had had the condition quite a long time. So 12.1 years was the mean duration of the condition. And perhaps reflective of how long they'd had that condition, nearly 3/4 of them experienced freezing of gait at times. And they asked people to describe what sort of things triggered freezing of gait, but also what sort of things were helpful and would relieve it. And of the things that most commonly induced freezing of gait, so these are the top 5, the 3rd to 5th are all things that the lockdown probably is creating. You could argue that fatigue is in there as well, actually. So this is a situation that, although necessary, is almost designed to worsen people's freezing of gait. What things did people report helped? Well, the good news is that the things that we're probably recommending already, so cues, whether they're visual cues or auditory cues, were the things that were most likely to be helpful. So we certainly need to be making sure that we're giving people access to information about that. There may not be the normal levels of access to face-to-face therapy that people perhaps would be able to get. So we should be looking at other ways to help with that. So perhaps if you don't have a leaflet on a few simple cueing techniques, it might be worth putting one of those together. There are apps. One, for example, that I think is quite a good one is the Parkinson's Home Exercises app. It's a Dutch app, and it's got lots of video of exercises. And also on the web, there are lots of exercises recommended for cueing. I think it'd be worth checking them out before recommending them. But I think we need to be thinking about other ways to try and help when the usual access that people would have isn't there. And then the 4th thing I wanted to talk about was amantadine, which is possibly about to become something of a hot topic. The Daily Mail recently ran this article looking at repurposing existing drugs to treat COVID-19, and it was based on a paper, and they mentioned specifically 4 drugs, and of those 4, amantadine was one of the ones that was mentioned. And as you can see there, it was once applied as a treatment for influenza. Where did the article come from? Well, it was based on this British Journal of Pharmacology paper, and essentially what had happened is a group of pharmacologists have looked at the evidence on existing treatments and to see if they could identify drugs that potentially should be researched further as possible treatments for COVID. And what they found is that amantadine, which, as I said, was used as an influenza A treatment, it was found to inhibit something called E protein, which was part of the SARS virus, and therefore there's a question about whether it might also be effective in the COVID-19 virus. And around about the same time, this paper was published. So a group of scientists in Spain had looked at a technique, it's a sort of computer modeling technique called molecular docking, and that suggested that within the COVID-19 virus, there might be some kind of interaction between amantadine and this thing called protein E. So therefore, amantadine might be something that should be looked at. Is it being looked at the moment? Well, this is the register on clinical trials, and you can see at the moment there are no ongoing trials for amantadine and COVID. Just to give you a sense of how that compares with other drugs. So azithromycin, there are 77 studies ongoing. So at the minute, it is purely at a theoretical stage, no current studies looking at it. This is the UK's largest COVID treatment study. And at the moment, amantadine isn't a suggested treatment. So what would we say if somebody asked, can I go on amantadine? I've heard it's going to protect me from COVID. I think we would just stick to its current indications, really, which are predominantly as an adjunctive therapy for motor symptoms, especially dyskinesia, and it might have a role as adjunct or monotherapy in people with other akinetic rigid syndromes. But at the minute, I won't be recommending that people go onto amantadine for any other reasons. So coming back to the question about what advice we can give people. So Parkinson's UK, they picked up on the change of tone at in the middle of May. And having gone through it, their opinion is that as far as people with Parkinson's are concerned, there is no significant change to what they would recommend. And actually, on the day of the change. During the government 5 p.m. briefing, Professor Chris Whitty actually picked up on this. I wonder if he realised that there wasn't any specific mention for neurological conditions in the new guidance, and so he said, I don't see it, that this is the time to start revisiting those bits of advice. So I think they're saying, you know, people with Parkinson's should be taking additional precautions over people who don't have Parkinson's, but not the level of people who are in the shielded or highly vulnerable group. There is a little bit of more specific advice that I think is worth looking at, actually, from the Movement Disorder Society. So they've looked at a few sort of specific things. First of all, they've advised that inpatient treatments should be probably postponed or even avoided for people with Parkinson's for the time being. And specifically, they talk about postponing deep brain stimulator surgery, which sounds very sensible for the time being. They specifically recommend substituting outpatient visits for telemedicine. At the moment, we are doing a lot of telephone calls, but I think there is an impetus now to look at whether we can bring in more video assessments, for instance. They do recognise, and I think it's important to do this, that the advice to stay at home, whilst essential, does have some consequences. And those are potentially physical, but also, as Sarah pointed out, there are also sort of psychological consequences of staying indoors. And they talk about the importance of maintaining people's normal medication during a COVID infection. No mention of increasing medication, and certainly we wouldn't want people to miss their medication. So that's all I want to say for now. Thank you very much.
Thank you very much, Richard. Have you had any or many patients on duodopa or apomorphine? Just people who are not on tablets, but obviously on more invasive type treatments, or have you heard how they're being managed in this time?
So far, I haven't heard of any problems. I think we don't actually have any patients currently on duodopa. We've got somebody who's about to start, but that has been postponed as well, understandably. But no, we've not heard any problems with people on infusional treatment in terms of either effectiveness or getting hold of it.
There are a number of questions about restarting services, and I think we'll do those at the end when we have all three of you. But I just wanted to ask you, we were discussing beforehand about anosmia and hyposmia and the effect that it's now been reported as being a recognized symptom of COVID. And will this affect the way, excuse me, people with Parkinson's present, or people without Parkinson's but with hyposmia present to Parkinson's physicians in the future? And will there be any loss of the association between hyposmia and Parkinson's?
Yes, thanks, Conor. I think it's a really interesting question. And I think one of two things will happen. It will either raise the awareness of olfaction as an important sense, and the loss of it as being something that should be looked into. So there is a chance that if people maintain the awareness between the symptom of hyposmia and Parkinson's, that we might get referrals earlier, perhaps even in a pre-motor condition, perhaps if people are particularly aware. On the other hand, I think there is the chance that what it might actually do is just make such a strong link between loss of sense of smell and COVID that people forget about Parkinson's altogether, and that it's something that only gets picked up in clinic. So I think only time will tell. It's probably helpful that people are thinking about sense of smell, though, as an important symptom.
Okay, I see somebody has noted that apomorphine and duodopa nurses have been very effective at making remote alterations to pumps, which is gratifying. Somebody else says, you speak about not being on the list of conditions requiring self-isolation, but I've been asked by a 59-year-old gentleman wanting to return to work. According to the government website, he should be able to return. What advice would you give?
Gosh, so I guess it depends what that person's work is. So given that both Parkinson's UK and Chris Whitty have said that the mid-May alteration didn't change anything in terms of people at additional risk, that still places somebody with Parkinson's who's under 70 in a group of people that should be taking additional precautions. So for me, that means asking the question, is it absolutely essential for you to do this? And I think of things like going to the shops as being one of the things that, if you've got Parkinson's, maybe somebody else, if they could do it for you, should be doing it. So in terms of work, there is a very strong argument against returning to work, particularly if it's in an indoor space, I think. And I think it would be something that, if somebody had a query about it, it would be well worth, discussing that with their Parkinson's team and just sort of weighing up the pros and cons.
Okay, thank you. One other question that Sarah touched on, and you have as well, is about impulse control disorders. And you had talked about noticing a lot of online shopping boxes left out for waste collection on your road. Similar here. I phoned my brother the other day, and he was doing online poker with friends. And not related to either of that, but there's also, I know, been a large rise in use of pornography in this time of opening up people with all conditions to the availability of impulse control disorders. Do you think people with a predisposition to impulse control disorders with Parkinson's could be potentially overwhelmed at the moment?
I think it's a concern, because I think to allow an impulse to become an action, first of all, you have to have the impulse, but then you need the opportunity. And the amount of time that people are spending indoors on computers, on their phones, means that there is much more opportunity to do things surreptitiously even. You mentioned about the cardboard boxes. Every single house on our street had a pile of cardboard next to the recycling bin, so people are doing lots and lots of shopping. There was recently quite a bit in the news about changes in people's online gambling habits. So there is no sport really to speak of for people to gamble on. So people who are betting are betting more on casino type games, and casino gambling seems to be more associated with problematic gambling. So that is a concern. So I think one of the things that we perhaps need to be doing is really taking every opportunity to make sure that people are aware of these risks, thinking about how we use the time outside of our consultations to help people be aware. So one of the things that we do now, so we've been sending copies of letters to our patients for some time, but we increasingly use a thing called a snippet at the end. So it's a bundle of information aimed at the person with Parkinson's, of things to look out for. And in particular, we mention looking out for impulsive behaviours of any sort and letting us know if they have any concerns, because I think the more ways we can give people of recognising a problem and telling us about it, the more chance we've got to intervene successfully. It is a concern.
Thank you very much. One thing I've noticed, it was actually said to me by the wife of one of my patients, that she said, when I come to the clinic and my husband answers the question, I can sit beside him, just behind him, and nod my head or shake my head and give you visual signals as to what he's saying is correct or not. And this was somebody who was involved, had impulse control disorders, and said he wasn't using things. Thank you very much, Richard. We'll go on to our third speaker today, who's Dr. Emily Henderson. And Emily is a consultant geriatrician and lead for movement disorders research at the Royal United Hospitals Bath NHS Foundation Trust, and honorary consultant senior lecturer at the University of Bristol. So I'll hand over to Emily.
Thank you very much, Conor. Good afternoon. Thank you. So I've been given a slightly wider remit just to talk about how we can gain better understanding of the potential impact of COVID-19 for our patients with Parkinson's and related disorders, really, by looking at the wider context of COVID-19 in older people. We recently published this review in Age and Ageing in conjunction with Victoria Hornton from Leicester. And very much like Sarah, this was born out of a really quite urgent and unmet clinical need, whereby I was also working on a COVID ward. And we were all really struck by the fact that there was a lack of evidence and guidelines as to the specific management of COVID-19 in older people, both in terms of how it presents, potential testing mechanisms and treatments. And so therefore, we set out to rapidly review the clinical evidence in those areas. I think there are two areas that it's useful just to focus on this afternoon. One is the presentation of disease in older people, and then potential future directions looking at research opportunities. In terms of presentation, people who look after older people will be familiar with the fact that they often present with symptoms that are atypical and non-specific for their illness. And there's no reason to think actually that COVID-19 would be any different. When we actually looked at the literature around this, there was curiously little across the whole world. In fact, the only literature we could find was from the French Geriatric Society, suggesting early reports that older people did present atypically with diarrhea and balance dysfunction and potentially delirium. Richard has already stated that COVID-19 tends to affect older people most severely, and indeed Parkinson's disease is a disease of older people. So it would be very reasonable that we can extrapolate those findings to people with Parkinson's disease. Certainly from a clinical perspective, we are seeing older adults present with COVID in very unusual, atypical ways. We're seeing patients present with delirium, either as an index problem when they first come into hospital, or alternatively during a hospital admission. We certainly had patients that have developed 24 hours of hypoactive delirium that could not otherwise be explained, but with some biochemical abnormalities who have then made a spontaneous recovery with likely COVID. Similarly, we're finding patients are presenting with, say, an index 4, and then on imaging, they're found to have fractures, but when we image the chest with CT, they're also found to have COVID findings without the much promoted symptoms that the government is suggesting of fever and cough. I think it's very helpful in those sort of settings to look more carefully for COVID infection, look for the radiological features, both on CT and chest X-ray, that support the potential diagnosis, as well as some of the biochemical findings, including lymphopenia. As far as I'm aware, there's been one case series so far that's looked at COVID-19 infection in people with Parkinson's, and that was published by Ray Chowdhury's group. I think the take-home messages from that were that there were preciously few numbers. So that was a series of 10 patients with COVID-19 infection. 9 out of those 10 patients were indeed older, over the age of 75, and unfortunately 4 of those died as a result of the COVID infection. A really interesting finding was the symptoms and signs that have precipitated testing for COVID-19 with the 3 Fs, and that was fever, fall, and fatigue. And I think some of the other speakers have already touched upon the importance of fatigue in the rehabilitative stage. I think we should be proactively looking for a step change in fatigue as a potential presenting symptom of COVID infection in people with Parkinson's. The review article that we've published found that actually there are very few specific articles that focus on the presentation of COVID-19 in older people, less so even with Parkinson's disease. Actually, there was no specific advice about testing older people generically, but also in terms of testing in different settings, be that nursing homes, primary care, or secondary care. When we think about the future directions and real needs in terms of research, I think looking at testing in those different settings and the indications for testing is really important. Similarly, I think it'd be really helpful to delineate more accurately what atypical presentations older people and those with Parkinson's have when they do present with COVID illness, and obviously then improve the sensitivity of testing that we would initiate in those scenarios. So far, we don't know whether treatments are any more or less effective in particular subgroups, those with neurodegenerative illness or older adults, and that's certainly a need that needs to be met. And finally, again, the other speakers have already touched on the fact that the public health measures, such as social distancing and isolation, are likely to have an intermediate to long-term effect on people's general health and well-being. I think it will be really important to identify the negative sequelae of those in terms of isolation and loneliness, and deconditioning has been mentioned already. And finally, there will be some negative and unfortunately catastrophic indirect consequences of those public health measures and the effect of COVID-19 on the health system in general. in terms of the neglect of other comorbidities and Parkinson's as well. It will be important to proactively look out for those and try and mitigate those risks insofar as possible. Thank you very much.
Thank you very much, Emily. Can I ask you about lymphopenia? As one of my trainees said to me the other day, which I thought was very apt, I've never really looked at the lymphocyte count in the past, and now I'm looking at everyone has a relative lymphopenia. And should we be doing swabs in our older population, but even, including those with Parkinson's who come in if they have a mild pyrexia, maybe a UTI, but have a slightly reduced lymphocyte count?
I would say personally, not wanting to fill the shoes of Professor Whitty, I think we should adopt a much lower threshold for testing older people, particularly when there's atypical symptoms, symptoms that are just relatively unexplained, or really anyone that is coming into hospital, because I think we are finding COVID infection incidentally. Will it make a difference to their care? Perhaps, insofar as we can offer oxygen supportive care, I think it might help us prognosticate, and it may help from a more sort of public health measure in terms of isolating patients with the disease from other people who are then highly susceptible by being in hospital. But I agree, the old lymphocytes have sort of been there forever. We've never really paid them any attention, and now they're the big stars of the biochemical show.
The other thing we've noticed is that people coming in with falls and fractured hips, and they're managed by the orthopedic or trauma teams for that, and then subsequently found out to have COVID. It links into what you were saying. It's doing early vigilance and testing, and delirium is the other a presentation that we've seen quite a bit. Have you had similar experience?
Very similar, in fact, and I think it remains to be seen whether those people have COVID infection in the community and as a result of that are falling and then coming into hospital with COVID, or indeed are having a fall for all the reasons people fall and then come in and acquiring COVID infection in hospital. Some of the early case series did seem to suggest that fever didn't always need to be present at presentation, but could be acquired during the course of a hospital stay. But I think we've seen a lot of hyperactive delirium, which is then very difficult to manage on wards that are closed and locked. And Sarah's described all the problems with communication and PPE. And indeed, hypoactive delirium, we've had people just flat for 24 hours with no source of obvious bacterial infection, but a change in CRP and biochemical markers, who are likely to have had COVID infection, which was otherwise asymptomatic, certainly from a respiratory perspective.
Thank you very much. I'll ask you, there's a number of questions have come in about restarting seeing patients. And if I could ask you first, Emily, and then I'll ask Sarah and Richard. I'll read out some of them. Very keen to see clinic patients face-to-face again. What are others doing nationally? How and when do you think we'll be reintroducing clinics? And how are you planning to manage new referrals? They're all kind of interlinked, but it's review patients and new patients. When do you think you'll be running up clinics again to see patients face-to-face? So going down to the southwest of England first.
We've been extraordinarily fortunate in the southwest. I think we're the least affected area of the country. And therefore, we're all trying to convert from our sort of COVID rotas to more of a business as normal case from the 1st of June. That's not, however, to say that it's business as normal in terms of our clinics. I should probably say what we're aspiring to do, not what we've successfully yet managed to do. But largely, we're trying to stratify patients based on their risk and then make decisions about their whether they have technology accessible to support either phone calls and or video conferencing, recognising that what we hope to be a small minority of people we are going to have to see face-to-face. But there's still quite a lot of work to really flesh out whether that face-to-face seeing people is going to be in a clinic setting with cleaning of rooms between people. Do we go from room to room like orthopaedic surgeons seeing people while there's cleaning, or do we go out and see people in their own homes or nursing homes and residential homes with PPE? So our aspiration is to stratify people on the basis of risk and their availability of technology, but we by no means have that wrapped up yet.
I know a couple of weeks ago when Baz Bloom was talking on this webinar, he was talking about doing video assessments of people and looking, you can check bradykinesia. I just find in older people that's going to be a lot more difficult, because it's if you're somebody who's doing that movement, it's very hard to tell if it's bradykinesia related to multiple factors or related to Parkinson's. I don't know, Emily, do you have anything to add to that? And then I'll go on to Sarah and Richard.
I agree. I mean, I think when we see older people, it's very rarely about those pure motor UPDRS signs. It's the moment you clap eyes with them in the clinic room, they stand up from the chair, they walk in, the strength of their handshake as they shake your hand, the assessment of all the comorbidities, and unraveling these long medication lists as much as anything else. I think there's so much we do as geriatricians that is not simply about pure Parkinson's, but about integrating those other comorbidities and their function abilities in making a diagnosis and then making a determination about what treatments might be effective. I think without that ability to communicate face to face and see people physically will be immensely challenging. Not impossible, but extremely challenging.
Sarah, I'll go on to you and find, do you have anything to add about assessing older people by video? I know we're not doing it in Lothian quite yet, number one. And number two, when do you think you'll be seeing new patients and review patients again?
I mean, I would echo most of, everything that Emily said, particularly the final points that I think we're making compromises because we have to, but I think there's no surrogate for seeing the patient. We're trying to diagnose and manage movement disorders, and you need to see people move. And as you were speaking then, Emily froze for a moment, and if you were trying to assess bradykinesia, on my screen no one moved for about 10 seconds. Speech as well, it's all affected. So similarly, moment largely doing telephone consultations, trying to look at how we could do video. I suppose my current way of thinking is that I imagine we might move towards having a kind of mixed clinic where we have a small number of patients coming up, very staggered, say one at the beginning of the morning, one at the very end, some phone calls in between, and maybe some video consultations in the middle to try and help with social distancing and targeting the right modality to the right patient. New patients I've just been speaking to by phone, I've kind of been pleasantly surprised by how much you can get by phone for someone you've never met. It's taking me longer than it would face to face, because I think you miss some of those non-verbal cues and you have to ask for more description. But I've actually found there's quite a few that I think actually by phone I'd be confident you probably have Parkinson's, or I think you've got essential tremor or vascular. So I think I've always said it's mostly in the history and it's kind of being borne out, but I think at some point we have to work towards seeing people. When, I don't know, not sure. I hope soon, but I'm not sure it will be.
And Richard, in your area?
So one of the things I've reflected on is how much that non-verbal communication is really important, both directions really. So I'm finding on the telephone, I'm having to use a lot more words to try and get across all the things that I sort of used, a smile and eye contact and all that sort of thing to put that person at ease. So that's one reflection. When will we start seeing lots of people face to face? Probably not for a while, really, because I think for a while the risk is going to outweigh the benefit of the extra bit you can't get through some remote means. We aren't yet doing video consultations. I think that will help, but yes, it's not the whole answer. So we do need to think very differently about how we do the whole assessment process. There was a specific question on new patients. So we sort of divide our new patients into three categories. The first category are patients that have already got a diagnosis of Parkinson's, but they're transferring from another service. So I'm happy to speak to those people on the telephone. I think we can often help. There is an argument for them perhaps staying under their original service, because the most common reason for people transferring is that they've been going to somewhere far away and the travel has become a problem. So there is an argument that for those people, they may well be better off staying for the time being under the original team. But I'm happy to speak to somebody who's got a diagnosis. There are people who have symptoms that we're very unlikely to treat with medication in the short term. And for those people, we are deferring their assessments. So initially we've gone for about 4 months, I think we went for, to say we'll look at them at this point. So the kind of things I'm thinking about are people who have either minimal symptoms or tremor only, or people who've got cognitive impairment that's so significant that we're very unlikely to start Parkinson's medication, the benefits of seeing us face to face would be outweighed by the risks, I think. And then the final group of people who don't have a diagnosis and report that they're really struggling, we've been bringing small numbers of those people up to the hospital for an assessment, not overlapping with another patient. Everybody wears a mask, gloves, apron, and of the three that have come, 2 out of 3 have started treatment on that day. So for them, hopefully, it's a useful thing to have done.
One of the things we've been exploring is doing clinics outside the hospital, so in community treatment centres or the equivalent, so that people are still anxious about coming to the hospital. I don't know if any of you want to comment. Some people have asked about doing cognitive assessments by telephone, and do you have any tips or suggestions for doing telephone or virtual cognitive assessments that could be used?
I'm not an expert on remote and telephone testing of cognition. I think we probably need to ask the question first about what's the urgency. So what's going to change if the mocker is 26 versus 14? And if the answer is, well, I'm thinking about, say, starting rivastigmine for cognitive impairment or potential dementia, then we probably could afford the luxury of 2+ months to then reassess. I don't think we would lose such ground in that time. That would make a significant difference. If people really are keen to get a handle on an actual number and what the impairment is like, then we did do a piece of work a few years ago where we used the Test Your Memory score, which is a self-completed cognitive impairment test. It takes about 10 or 15 minutes. It often requires someone just to sit with them, and that can be their husband, wife, care partner, daughter, whoever, because at the end you get 5 points depending on whether you needed any intervention or help, and the patient just completes that themselves. And we did a piece of work that then mapped that score onto a mocker, so you can see what their equivalent mocker would be. If there really is an urgency, you could do that remotely by posting them with that.
Okay, I don't know if Richard or Sarah have anything to add to that. I think we're probably singing from the same hymn. From Glasgow, Anne-Louise Cunnington has just said, we're screening all over 70s being admitted, and every 4 days thereafter during admission, if negative. She asked if it was just in Glasgow. Jacqueline Dallas said no, Tayside are doing it too. I know it's being done in Lothian. What about down in England? Richard or Emily?
So we're screening all emergency admissions with a plan to screen all admissions. In fact, that may be happening now. So we are picking up a small number of people that you would classify as completely asymptomatic. I guess if you look hard, well, there's a reason people come into hospital. So, but they're not symptoms that you would classically think of as COVID symptoms. So yeah, everybody's now getting tested. And some people do get a retest, particularly if if they have symptoms that are strongly pointing to a COVID infection, or typical X-ray changes, for instance, or the lymphopenia that we talked about. But with a negative test, they usually get retested.
Very similar, but I think we do need to just keep at the top of the agenda the sensitivity of the nasopharyngeal swabs, and just keep in mind that a negative test does not mean that you don't have COVID, as I'm sure many of us would also personally attest to.
And as it's approaching 4 o'clock, I'll finish up with a question. Any tips for coping with the length of consultation on the phone? I'll just give our own experience. What we've tended to do here is we send out a letter in advance saying we're going to be phoning you and if you have any questions, write them down in advance, and then we use a pro forma to go through specific questions. But has any of the three of you got any tips about ensuring that the consultation is of reasonable length?
I think I'm probably most to blame in the two-way dialogue. If it's long, it is, I find, longer than face-to-face, but I think that's probably my fault, not the person on the other end of the phone. I think, as Richard says, I'm talking more than I would if I met someone. I'm trying to tease out what they're experiencing, what they're seeing, and you probably need to use more words to explain something than to demonstrate. So I think it'll be about me learning how to get more succinct rather than the other way around. I think I'm to blame for the long consultations.
Emily or Richard, any tips?
I'm trying to use this opportunity as a sort of chance to look at the way that we do things, like consultations and other things that we could be doing better. I'll see if I can just quickly share something that it's from a Swedish Parkinson's blog. So this is somebody with Parkinson's, but I think it illustrates very nicely, I think, a useful concept, which is, I think, I would like us to be looking at ways to try and make more use of the time outside of the consultation. So this person very neatly points out that they might spend an hour a year with their specialist, but there's nearly 9,000 hours a year where they're kind of managing themselves. And so I think if we can find ways to make more use of the time before and after clinic, so I think things like a pre-clinic questionnaire, it's just about managing the industry around that, and then including information afterwards, whether it's leaflets or putting stuff in letters, helps to, extend the time of that consultation beyond the time that you're actually talking to the person with Parkinson's.
Yeah, I certainly think that somebody was asking about, will our amount of face-to-face consultations reduce in the long term? I know that the feedback that we've had on the questionnaire is very positive about telephoning patients, now particularly at this time, because a lot of people are stuck in their houses, and they very much appreciate the doctor taking the time to phone them up and check how they're doing at this time. I also feel that I might reduce the rate of seeing people back in the clinic and do more telephone or video conference clinics in between, so that we can keep that link with the patient, because it has been so well received. With that, it's just gone 4 o'clock. I'd like to thank our three speakers, Dr. Sarah Marrinan, Dr. Richard Genever, and Dr. Emily Henderson. I'd like to thank Sarah and Hugh, who have coordinated this on behalf of for the Parkinson's Academy. And thank you to all those who have tuned in, and hope to meet you again at the next webinar that we run.